Good afternoon. I'm Stephanie Moore, Project Manager for the Association of Community Cancer Centers. I am eager to introduce Dr. Sanjiv Agarwala as our expert presenter, the 14th webinar of the series hosted by the Institute for Clinical Immunology, ICLIO. As you may know, ICLIO is an institute of ACCC and is the only initiative to prepare multidisciplinary cancer care providers for the complex implementation of immunology in the community setting. The ICLIO program provides a host of educational sources and tools such as webinars, newsletters, e-learning module courses, tumor subcommittee updates, and an immersed IO visiting expert program and live meetings. Now for today's webinar, I am pleased to introduce Dr. Agarwala, Chief of Medical Oncology and Hematology at St. Luke's Cancer Center and Professor of Medicine at Temple University School of Medicine in Philadelphia, Pennsylvania. Dr. Agarwala is also an esteemed member of the ICLIO Advisory Committee. Dr. Agarwala is national and international recognized as the expert in the research and treatment of melanoma and immunotherapy of cancer and has presented and led numerous conferences and meetings across the globe. Dr. Agarwala has written and contributed to over 150 publications and book chapters on melanoma and other research areas. He is board certified in oncology, hematology, and internal medicine, as well as an active member of several professional and scientific societies, such as the American Association for Cancer Research, the American Society of Clinical Oncology, the European Society of Medical Oncology, and the Society of Melanoma Research. Dr. Agarwala has been the principal investigator for multiple clinical trials involving immunotherapy and target therapy for melanoma, as he has special interest and expertise in immunotherapy for cancer. As a result of his dedication to melanoma and immunotherapy research, Dr. Agarwala has received several honors, including listings as one of the American top doctors for cancer and best doctors in the United States. Now for a few housekeeping notes. Feel free to submit questions to our presenter by typing questions in the box on your dashboard. I will pose questions to Dr. Agarwala at the conclusion of his presentation. The webinar will be archived and available on the ICLIO website, accc-iclio.org. Now, I'll send it over to Dr. Agarwala to kick off the webinar.
Thank you, Stephanie. I'd like to welcome you all also, and it's a pleasure to talk to you about melanoma and the choices that we make or try to make in the clinic every day for metastatic melanoma patients. So I'm going to do a brief introduction and some background, and then I'm going to basically do this in a very clinical format where we'll be going through questions that I ask myself in the clinic every day, and that way give a perspective on how we approach this clinically, and I will end the webinar with some future directions because, as you all know, there's been a lot of advances in melanoma and a lot that's still going on. So next slide, please. So let's first look at, the melanoma landscape and how it was and how it's evolved. And I like to use 2011 as the landmark year. Really, that's when everything changed. And prior to 2011, really our choices outside of a clinical trial were chemotherapy with dacarbazine or DTIC, which is not a very good drug. As you can see, response rates single digits and really never ever shown an impact on overall survival. High-dose interleukin-2, certainly a drug that we have used quite extensively, but has issues, a low response rate, about 5%, but they're durable, which has made this drug attractive. But it requires specialized centers to give this, and it's really not used much outside the USA for sure, and even in the US now, it's really not being used that much, as we'll talk about some new advances that have taken place. Next slide, please. So next slide, Stephanie. So if you look at the data in terms of what I like to call the pre-PD-1 era, and this is post, of course, 2011, when there was immunotherapy drugs like ipilimumab and anti-PD-1s approved. If you look at survival, and this is data from CORN, a meta-analysis in multiple clinical trials, phase 2 trials, more than 2,000 patients, a very dismal 12-month overall survival of 25% and a median OS of only 6.2 months. So really no progress and not much that was impacting this very poor survival curve for metastatic melanoma prior to the approval of these new and exciting agents. Next slide. So what's really changed in terms of cancer treatment in general and melanoma in particular is that we've gotten smarter. We are able to now, as targeting something, and as you can imagine, if you don't target something, you're not going to get a good outcome. And our treatments in the past were quite crude, non-targeted approaches. But now we're either targeting the tumor directly, and on the right side you see what we call targeted therapy. So you have a mutation such as a Bereft mutation, and we can target that, and we'll talk about that. Or we can use immunotherapy, but in a targeted way, and I like to call that targeting the host. So it's not non-specific immunotherapy, it's immunotherapy targeting specifically certain pathways in the host that can be manipulated to help and produce an anti-cancer effect. Next slide. So let's look at what our options are for metastatic melanoma in 2017. So we obviously have clinical trials, and I'm not going to talk about them today. That's always the first option we should always consider. But really, we have to choose between overall immunotherapy and targeted therapy. And let's talk about each of these. The next slide. Let me start by simplifying immunotherapy in this one sentence that let us assume that in 2017, immunotherapy for cancer, and for melanoma specifically, is the same as using a checkpoint inhibitor. Now, obviously, there are other immunotherapies available, but in the clinical practice, we are really using the checkpoint inhibitors as our immunotherapy approach. Next slide. So let's look and see what a checkpoint inhibitor is, and let's start by defining what is a checkpoint. So this simple diagram shows you what the immune system is doing, hopefully appropriately and hopefully effectively, in terms of controlling tumor growth. And the immune system is very important for tumor control, as you all may know. So if you look at the tumor releases antigens. Those antigens get picked up by an antigen processing cell, like a dendritic cell, for example. They are carried to the T cell, which is often present in the lymph node. The T cell is activated by various processes. That activated T cell goes back to the tumor and destroys the tumor by various mechanisms. So that's a simplified approach, and we hope that happens every time. Now, obviously, it's a very powerful system, and any powerful system needs to have checkpoints on it, or breaks. And as you can see in this diagram, there's various checkpoints. Two of them have been shown here. And these checkpoints are what are important to protect ourselves, our bodies, from too much immunity. So if you don't have checkpoints, you're going to have immune hyperactivation all the time, because we are always reacting to antigens. May not be tumor antigens, but other antigens as well. And there need to be breaks on our immune system to keep this in check. So these are checkpoints. Next slide. So let's now examine what is a checkpoint inhibitor. Next slide, please. I like to use the analogy of a car. So if you consider that your immune system is a car, your checkpoint is the brake on the car. So shown here is a car and various parts of the car, such as the gas pedal, which of course gets pushed upon, and the immune system moves forward. The antigens steer it, but the most important thing is the brake. And as you can see on this picture here, the brake is the checkpoint, and the big X on that brake is the checkpoint inhibitor. So a checkpoint inhibitor is really a brake remover from this immune system car model. So taking the brakes off the immune system is what a checkpoint inhibitor does. Next slide. Now, there's two checkpoint inhibitor pathways, or two brake removers, if you will. One is called CTLA-4, as you may know, and the other is called PD-1. So if you look at CTLA-4, the differences between the two, CTLA-4 affects what we call the priming phase of the T cell activation. So the T cell is activated, and we call this the afferent pathway. That's where CTLA-4 works. Next slide. And PD-1 works mostly on the effector side of the T cell, so the other side, that is the side facing the tumor, if you will. Now, this is, of course, an oversimplification, but as you can see, if you think about the T cell in the middle, you have the CTLA-4 on one side and the PD-1 on the other. They both work at different places, but you can also consider putting them together for synergy, which is what we have done, what has been done in immunotherapy, in melanoma, and in other diseases. Next slide, please. So now let's move to the clinical side of the discussion in terms of what are the questions that I ask myself in the clinic every day when I see a metastatic melanoma patient. Next slide, please. And the 4 questions that I have to go through in my mind, and I'm going to go through in this talk, are these. If I'm going to pick immunotherapy, what are my options? If I do pick immunotherapy, should I use a PD-1 monotherapy or a combination with CTLA-4? How about targeted therapy? When should I pick that? What are my options? And in a positive, BRAF positive patient, how do I choose between picking targeted therapy and immunotherapy? So 4 questions I'm going to go over, starting off with what are my options for immunotherapy. So next slide, please. So the immuno-oncology timeline, we all show this picture just to make the point that immunotherapy has been around for a long time. In fact, in 1882 was the first experimental, very crude immunotherapy done by William Coley and his mixed toxins. But we fast forward to 2011, where now we have these so-called targeted immunotherapies that are much more effective. And I do want to point out that, it's really taken more than 100 years to get a highly effective immunotherapy out there. It's just been a difficult and a long road. But finally, we are having success, not just in melanoma, but other cancers. Next slide. So the checkpoint inhibitors have made a big splash, and you can see here that they made the cover of both Science and Nature magazine journals, and these are very important journals. And really, I'm going to go for the rationale for this and the data with this in terms of what are we considering as these drugs. What is the data in melanoma? Next slide, please. The checkpoint inhibitors approved for melanoma are the following. We have the anti-CTLA-4 antibody ipilimumab. In anti-PD-1 inhibitors, we have 2 approved in melanoma, pembrolizumab and nivolumab. And then we also have a combination FDA approved of CTLA-4 and anti-PD-1, which happens to be ipilimumab and nivolumab combined. Next slide. Let's start with ipilimumab. And this is just summarizing 2 important clinical trials for this drug. The left side of this picture, this slide, shows you the landmark trial that actually was the one that changed everything. This was a 2011 presentation at ASCO, and it was a trial comparing, best way to look at this is it's a comparison between ipilimumab and a vaccine. There were 3 arms, and there was a combination arm on there, but essentially ipilimumab was better than a vaccine as a control arm. And this is second-line data. These are patients who had progressed on other therapies. And while vaccine, of course, is not a real standard treatment for melanoma, but those days anything was fine because really we had no standard of care anyway. However, there is a trial shown on the right side of the slide that looked at ipilimumab versus DTIC. In fact, it actually was a combination of ipilimumab plus DTIC versus DTIC alone. I'm not going to go into great detail, but essentially the left side trial here, the one that was second line, was the one that got the drug approved. The dose is 3 milligram per kilogram, given once every 3 weeks for 4 cycles. And that was the one that really became the standard for us if we use immunotherapy, both frontline and second line. Next slide, please. So this was the standard of care in 2011, which changed everything, as I said. Next slide. And, the really question is that it became the standard of care, but can we do better than that? And as you might have seen from those survival curves that I showed you, there was about a 20% long-term benefit rate or survival for this drug. Much better than what we had before, but still room for improvement, of course. So now let's look at PD-1, and this is the trial Keynote-001, which you may be familiar with, the largest ever phase 1 trial ever conducted, not only in melanoma but in other diseases. And this is the melanoma cohorts. And you can see this was a large pooled analysis of 655 patients in multiple different schedules and dosages, trying to get a sense of what does anti-PD-1 pembrolizumab do in melanoma. Next slide. And the updated data here presented at the most recent ASCO meeting shows a few things. It shows good progression-free survival, good overall survival. If you look at the curve, it looks good. In terms of response, you see that in the waterfall plot, the inflection point is 71%. Doesn't mean that the 71% response rate. It just means that at least 71% of patients had some type of benefit, and the overall response rate you see there and the median change. And the durability was good too, and the toxicity was very manageable. So good data overall in a large cohort of patients. Next slide. And in this updated analysis as well, when we looked at the patients who received pembrolizumab as frontline therapy, 133 patients, we actually had even a better outcome. So keep this point in mind as we address this later on in terms of frontline, second-line therapy, and so on. Next slide, please. So having good data with pembrolizumab, different groups of patients in melanoma, the question really was, okay, we're using ipilimumab frontline. What do we do if ipilimumab is not working or stops working? So this was the first important pembrolizumab trial where it's KEYNOTE-002, where after ipilimumab, what do you do? And this is a randomized trial of pembrolizumab versus really what's left in that setting outside of Bereft positive patient is chemotherapy. So you have a randomized trial of pembrolizumab versus chemotherapy, investigator's choice. Next slide. And this KEYNOTE-002 trial showed very nicely that progression-free survival, which was the primary endpoint of the trial, was better than chemotherapy. Now, this was a very good trial because it allowed crossover. It was a good trial for patients. But because it allowed crossover, PFS, progression-free survival, was the primary endpoint, and this showed clearly that this beat chemotherapy. So next slide showed us from this trial that if you use IPI first and it stops working or doesn't work anymore, then anti-PD-1 is better than chemotherapy in this setting. So our sequence of treatment became IPI first and then anti-PD-1 second, in this case pembrolizumab. Next slide. So that brings up the important question: if this works so well after IPI, what about using it instead of IPI? And KEYNOTE-006 was a very important study that compared frontline. Now, this is not second line anymore. This is frontline pembrolizumab versus ipilimumab, randomized trial, overall survival and progression-free survival as the primary endpoints. Next slide. And it showed in this trial very nicely. These are the baseline characteristics. You can see well balanced for the various subsets, subgroups, including BRAF mutation positive and the Pdl One positive and negative and so on. A representative patient population for metastatic melanoma where 64% plus patients had M1c disease. Next slide. And you can see nicely in this slide that the overall survival for pembrolizumab was better than ipilimumab. So very clear-cut data, OS improved. Next slide. And the same thing for progression-free survival, not surprisingly. Next slide. And response rates also significantly higher for pembrolizumab versus ipilimumab. You can see here the different breakdowns and complete partial responses, but overall response rate about 37% in both arms of pembrolizumab. These were different schedules of pembrolizumab tested, by the way. They're both identical, and ipilimumab was what you expect, about 13%. Next slide. Durability was excellent for the pembrolizumab compared to ipilimumab. You can see that the durability was great. Next slide, please. And our conclusions from this trial were that anti-PD-1 is better than ipilimumab frontline. And I haven't shown you the data in the interest of time, but there was also less toxicity. So this is a winner. You have a drug that's better in efficacy and less in toxicity. It's going to replace ipilimumab, and it did. So anti-PD-1 then became the frontline standard of care for us in metastatic melanoma, and this was FDA approved very quickly based upon this trial. Next slide. So if you can have monotherapy that works very well with each of these, PD-1 better than CTLA-4, of course, what about putting them together? So as I mentioned earlier, there is an approval of the combination. So the question is, should I use PD-1 monotherapy or combination with both drugs? Next slide. And this important study, Checkmate 67, this was also updated and presented by Jed Wolchuk, ASCO meetings multiple times. And this is a randomized 3-arm study of a combination of nivolumab and ipilimumab compared to nivolumab and ipilimumab, a 3-arm trial. Next slide. And as you can see from the data, it appears from progression-free survival, which are the only data we have at this point, that the combination looks better than either arm alone. Okay, so you've got the combination on top, nivolumab in the middle, close to the combination, but definitely separated from the ipilimumab alone in green. Next slide. I do want to point out a couple of things about this trial, though. This trial was a 3-arm study, but it was really powered statistically to only show the difference between the combination of nivolumab and ipilimumab compared to ipilimumab alone, and for nivolumab compared to ipilimumab alone, not for the combination of ipi and nivo versus nivo alone. So whatever data we're looking at in terms of the combination between, or the comparison between those two arms is an exploratory endpoint. Next slide. And also it is highly censored, many patients ongoing, and we don't have overall survival data yet. The other issue with this combination that we need to keep in mind is the toxicity. So you look at the side effect profile combination, the grade 3 and 4 toxicity rate in this trial was more than 55%. So that's a significant amount of toxicity, manageable but still significant and needs to be understood and can be problematic. And you look at the single agent data, the toxicity is much lower, especially for using nivolumab alone. Next slide. You look at the toxicity in more detail, you also see that the onset is earlier of the grade 3 and 4 AEs when you look at the combination compared to monotherapy. Not surprisingly, the toxicity not only is more in number, but occurs earlier. Next slide. And also takes longer to resolution. So you have data that, can you go back, Stephanie, one slide, please? Yes, so the toxicity is not only earlier, but it takes longer to resolution. So you've got to keep that in mind. This is a combination which looks like it might be better, but you have high toxicity that occurs earlier and takes a longer time to get better. Next slide, please. One of the things I do want to mention here is the issue of Pdl One expression. So as you may know, Pdl One is a marker in most cancers for efficacy of anti-PD-1 antibodies, and in melanoma as well. There is no doubt that PD-L1 positive tumors respond better to anti-PD-1 therapy. However, even the PD-1 negative tumors respond very well. So we don't really use this as a marker to select immunotherapy, yes or no. But what's interesting is, next slide, when you look at the, and this is nivolumab data showing the same thing. Next slide, please. When you look at the CheckMate 67 data, what is kind of interesting is that when you divide the patients up by, let's call them low Pdl1 expressors and high Pdl1 expressors, next slide please, you actually see that patients who have a low Pdl1 expression, looks like the separation is good when you use a combination, but when you have a high Pdl1 expression, the combination and the nivolumab arms overlap. So the take-home point here is that possibly, and this makes logical sense of course, that if you have a patient with a tumor that stains less for Pdl1, you might need a combination. Whereas if you've got a high staining of Pdl1, monotherapy may be enough. Now this has not been validated yet. This is an observation that is very interesting and needs to be validated, but perhaps one day we might use Pdl1 staining in melanoma as a way to decide whether a patient should get combination immunotherapy or monotherapy. But like I said, it's still something that's obviously not confirmed, and an interesting observation. Next slide, please. Next question in the clinic is targeted therapy. So for a Bereft positive patient, what are my options if I were going to choose targeted therapy for them? Next slide. And I think you all know the Bereft, MAP kinase pathway, and it's all based upon tyrosine kinase that act on the receptors. And you see RAS, and downstream of RAS is RAF and MEK and ERK, and then you have the of course, the nucleus, and there's various points along here that can be mutated and can be affected by drugs. So BRAF inhibitors like dabrafenib, vemurafenib, encorafenib work on RAF. MEK inhibitors like trametinib, cobimetinib, binetinib, they work on MEK. And as you can see, that putting them together makes sense because it's a vertical blockade and you might get better efficacy, and we'll come back to that. Next slide. So the landmark trial that changed everything for BRAF positive patients was this trial of vemurafenib compared to chemotherapy, DTIC in this case, which was a standard of care, as you might remember. And it's vemurafenib versus DTIC, metastatic melanoma, very impressive results, quickly accruing study, and it showed improvement in every endpoint, including overall survival. So early on, again in 2011, which was really a landmark year for melanoma in general, for a BRAF positive patient, you could use monotherapy with vemurafenib and get a very good outcome. Next slide, please. However, when you look at the MAP kinase pathway, as I showed you earlier, there is the potential to do double targeting. So you can target mutant BRAF, but you can also target MEK with MEK drugs. And the idea was, why not try to put them together and see if you can get a better outcome? Next slide. And indeed, this is one combination of vemurafenib and povetacicept versus vemurafenib and placebo called the COBRIM trial, showing quite clearly that combination therapy is better than monotherapy. So to cut a long story short, basically, when you're targeting the MAP kinase pathway in metastatic melanoma, you would use a combination therapy of a BRAF and MEK. And there's multiple combinations out there, at least 2 that are FDA approved. And the outcome is better in survival, response rates are higher, durability is better, and the most amazing thing is that toxicity is actually lower when you put the combination together, which is amazing. So the standard really would be, if you gave someone BRAF therapy or targeted therapy, MAP kinase targeted therapy with a BRAF mutation, you would use some form of a BRAF and MEK combination. Next slide. So you got good data with that in a BRAF positive patient, and in a immunotherapy choice with the BRAF positive patient, you also have good data. So what should I do? What are my choices? How do I choose between using immunotherapy or targeted therapy for a BRAF positive patient? So let's look at some data to help us here. Next slide. So let me go back to KEYNOTE-006, the randomized trial that compared IPI to pembrolizumab. And what I want to point out here, next slide please, is that when you look at the BRAF mutant, prior BRAF mutant therapy patients, this is the hazard ratios on a forest plot, and you'll see that they're still to the left of the line, which is good. That means it works. Next slide. But go back please. But it works better if you have no prior anti-BRAF therapy. This moves even further to the left. So the point is that when you look at the subgroups, you get good results in both BRAF positive and BRAF wild type patients with pembrolizumab, but it's potentially, from this data, more effective when you use it up front, which is interesting. Next slide, please. And when you look at the KEYNOTE-001, next slide, please, the phase 1 data, as I showed you earlier, it does look as if the waterfall plots look better in the treatment-naive group versus the total population. Good on both sides, and this is, of course, not a comparison, 71 versus 80% inflection point, but it does look like there is a hint that you might get a better activity frontline, which is, again, interesting as well. Next slide, please. What about the BRAF inhibitors? What's really fascinating about the BRAF inhibitors, and to me at least, in terms of their data, is when you look at whether you use them frontline, second line, etc. Next slide, please. The response rates in second line look really good. They look almost as good as frontline therapy, which is quite amazing that you have the potential for these drugs to work equally well if you use them frontline or second line. And that may not be the case with the immunotherapy data that I just showed you. Next slide, please. However, I do want to point out, in fairness, that when you look at the best patient populations in the BRAF trials, COMB-D is shown here, less than 3 disease sites, normal LDH, and of course, using them frontline, you have very good outcomes as well. And with longer follow-up, we're seeing plateaus, just like we're seeing with immunotherapy. So both of these groups both of these modalities have very good outcomes. And while the track record with immunotherapy is a little longer, it does appear that there is some long-term benefit with the combination BRAF-MEK therapy as well. Next slide. So really, we don't know what the right approach is right now. We have our biases, and many of us will pick targeted therapy for a patient who has more symptoms, more aggressive disease in our clinical judgment. But obviously, we don't have the correct answer. This ongoing clinical trial through the cooperative groups will maybe help answer that. This is a trial for patients with BRAF positive disease, randomized to combination immunotherapy versus combination targeted therapy, and at progression, a crossover. So a nice design, and let's hope this helps us get the answer, which right now is based mostly upon clinical judgment. Next slide, please. So how do I treat metastatic melanoma? This is my algorithm. Next slide. And it can go through the steps. So you make a diagnosis of metastatic melanoma. You look at the BRAF mutation test. I do that in all patients. If you're BRAF mutation negative on the right side of the slide, that's very useful information because it tells you don't use BRAF drugs. Don't use targeted therapy. And that's what I like about the Bereft test. Not that it tells you what to do, it tells you what not to do. So if you don't have the mutation, you're left with, of course, immunotherapy, which could be anti-PD-1, combination anti-PD-1 CTLA-4, or of course, IPI alone. If you have the BRAF mutation positive, then of course you have the option of giving them BRAF-MEK combo, anti-PD-1 monotherapy, combination CTLA-4-PD-1, or IPI alone. You'll notice that I don't even have chemotherapy on this anymore. I rarely use it, hardly use it at all, outside of a clinical trial, of course. And really, by the time patients now are getting the chemotherapy, it's almost time for palliative care. Next slide, please. So before I end, I'm just going to quickly go over some future directions because obviously we've made a lot of progress, but we have a long way to go. Next slide. And when you think about the various ways that we're going to try to improve immunotherapy and targeted therapy for melanoma, what are the options for us right now? Well, these are a few of them. We can look at other checkpoint modulators, and luckily there are more than just PD-1 and CTLA-4 in the clinic, in clinical trials, should I say. What about BRAF-MEK combination with checkpoint inhibitors? Let's look at that as a, combining all three modalities, if you will. One of the issues, of course, is that when you use combination immunotherapy with anti-PD-1, anti-CTLA-4, there's high toxicity, like I went over with you, but we also believe that that high toxicity is mostly from ipilimumab at the full dose of 3 milligrams per kilogram. So one of the strategies has been, can we lower the dose of ipilimumab to, say, 1 milligram per kilogram and get the same result with less toxicity? And we'll look at that. And then finally, a very unique and interesting approach in melanoma, which is, can we injure the tumor, release antigens that way, and therefore make it more vulnerable to systemic immune attack? And one approach there is oncolytic therapy. That a drug called TVEC is FDA approved, and this is a direct intratumoral injection as a monotherapy, of course, but combination trials are ongoing. And then there's other ways to injure the tumor, like radiation, perhaps, maybe even chemotherapy, make a comeback as a strategy to release antigens. I don't know, but these are the approaches that one could look at. Next slide. And this is the picture of the T cell surrounded by all the different modulators or checkpoints that one could exploit potentially. You'll see in red on the right side CTLA-4-PD-1. We use those already, but there is a host of others, and I'm not going to go into them, but there are some very exciting molecules out there, activating and inhibitory on both sides of this this coin or this T cell, and lots of clinical trials going on right now looking at these different pathways or different checkpoints in combination and monotherapy. Next slide. I do want to talk about the tumor microenvironment, and that's something we should not forget. So there's something called IDO and T cells, and just to summarize here, what we're talking about is that the tumor microenvironment has T cells in it, and there's different populations of T cells. And IDO is a molecule that, as you can see from this graphic here, it reduces the levels of tryptophan in the microenvironment and raises the levels of kynurenine, which really means simply that it increases via tryptophan the number of it increases the number of T regulatory cells and decreases the number of CD8 cells under baseline conditions. And therefore, if you inhibit IDO, you will do the opposite, which is increase the number of CD8 cells and decrease Treg cells. So just to clarify, what you want in the tumor microenvironment are the CD8 cells. You want less of the Treg cells. The T regulatory cells are a complicated cell, but in terms of the immunotherapy pathways, they seem to be detrimental to the immune response. So if you have an IDO inhibitor, and the big X is shown on this picture, you will do good things to the tumor microenvironment, which is increase the CD8 cells and decrease the Treg cells. And therefore, IDO inhibition has been a strategy that is being applied in the clinic. Next slide. So we have data now with what's called KEYNOTE-252, which is a combination trial of pembrolizumab as a checkpoint inhibitor with ipacadostat, which is an IDO inhibitor. And not to show you the data, it's been presented at ASCO, but now there's a randomized trial. The data look pretty good in terms of combination. So there's a randomized trial going on right now of pembrolizumab, ipacadostat versus pembrolizumab placebo. And this trial is accruing very well, and I think this might be something we should look for because in the initial results, the combination looked good and with low toxicity. So this may be the next thing, the next big thing for melanoma, but we'll wait and see. Next slide. Triple combination therapy. So something that has been tried in the past. You might recall some of the trials that were done originally with Bereft inhibitors and ipilimumab, and there were some toxicities that were unexpected and severe. So this is something we should not be trying outside of a clinical trial. And it's been a difficult combination, but maybe now this is the right combination. There's data with pembrolizumab, dabrafenib, and trametinib. There's a couple of other things going on as well, triple combination therapy, that are showing promising results and toxicity that's manageable. Next slide. So we might be able to, in the future, have a potential for a triple combination therapy for some patients who have a BRAF mutation, of course, and this is data from Keynote-22 showing durability responses and some very good waterfall plots in a small number of patients. So this needs, of course, further study and a randomized trial down the road, but this might be another strategy to exploit. Next slide. And finally, this approach of lowering the dose of ipilimumab. So to just recap, you got good data with PD-1 and CTLA-4, and the CTLA-4, of course, is IPI, given at 3 milligrams per kilogram, which is a toxic dose in this combination. What about dropping the dose of ipilimumab to 1 mg per kg and keeping the PD-1 the same? So this is pembro data, pembrolizumab plus IPI, Keynote-29, and it's not a randomized study, but some interesting results. Next slide. And you can see that from this analysis of this cohort of patients treated with this combination, the grade 3 and 4 side effects have dropped to about 25%. Now, we call that with the full dose ipilimumab combination, it was 55%. So that's a nice drop, which is encouraging. Next slide. And what's really nice to see is that the efficacy seems to be good. Now, it's not randomized data. This is a combination phase 1/2 database. So it is very provocative, but not confirmatory. It's looking like we're maintaining the efficacy and dropping the toxicity down to what looks like monotherapy toxicity, but we wait and see. Next slide. And then finally, the approach of intralesional therapy injuring the tumor. TVEC, as you know, is FDA approved, but there are other agents out there like PB10 and interleukin-12, HF10, Cavitac, intralesional therapies that are being developed for melanoma because, as we know, melanoma is unique in that 30% of melanoma patients have tumors, metastatic tumors, that you can reach with a needle. So you can exploit that to the advantage of the patient, perhaps, by releasing those antigens by injuring the tumor. And I'm not sure that monotherapy with intralesional oncolytic therapy is going to be of much use as a monotherapy in most patients, but I think combinations will be very exciting. Next slide. And there are several combinations out there. This is the one that's in the furthest along in development. This is a trial that's combining TVEC intralesionally with pembrolizumab given systemically, and it's a randomized trial now comparing the two versus just pembrolizumab alone. And in fact, there's going to be a placebo given intralesionally to make it very fair and very clean as a trial. And this randomized trial is ongoing at this point in time. Next slide, please. So, in summary, it's an exciting time for melanoma. Made huge advances in the last 3 or 4 years. It's incredibly good, but we still have a long way to go. There's been a revolution, certainly, in terms of checkpoint inhibitors and MAP kinase targeted agents for patients with advanced melanoma, depending upon whether they have a BRAF mutation or not. If you pick frontline immunotherapy in the United States, for us, it's either an anti-PD-1 monotherapy or a combination with anti-CTLA-4, and I showed you the data. And of course, we have to make our choices with our patients as to which one to pick. If you have a BRAF positive patient, you have 3 choices. You can give BRAF targeted therapy, you can use immunotherapy monotherapy or combination. And as I try to show you at the end, future directions are really going to look at multiple things, increasing efficacy, of course, but we've done very well in efficacy. We need to do better, but with what we have, can we keep the efficacy the same, perhaps, and lower the toxicity? So we're going to have to find different ways to tweak this. It is tough because there's so many potential combinations that can be tested, and it's going to be a big challenge to figure out which combinations to take to phase 3 and how do we find enough patients to do all the randomized studies we need to do to get these new combinations FDA approved as well. So I think that's all I have, and I will stop here and open it up for questions. Stephanie, it's all yours.
Thank you, Dr. Agarwala, for the engaging presentation. I actually have a couple of questions from our audience. Other than Pdl One expression, are you aware of other biomarkers in development for predicting response to a checkpoint inhibitor in metastatic melanoma?
Yeah, so that's a very hot question and a good question. I'm not aware of anything that's even close to clinical application. There are, very suggestive biomarkers out there. I think starting off with just the tumor mutation load, I think we know that any tumors that have higher baseline mutation load, and there's a very nice paper that examined this, and guess what the number one tumor with mutation load is? It's melanoma, and guess what the number two is? It's lung cancer, and it's kind of interesting how that was a sequence of approvals for these agents. There are other markers that are being looked at in terms of more dynamic markers where you give a dose of immunotherapy and then look at baseline and then changes in the tumor microenvironment and we talked about T regulatory cells and CD8 populations and so on, but it's fairly complicated and nothing that's clean cut and that can be done at baseline except the Pdl1. And I do want to emphasize that we don't use Pdl1 staining in melanoma to make treatment decisions whether to use immunotherapy or not right now, because even without Pdl1 staining, our results are much better than anything else we've seen. And we don't really have an approved Pdl1 test, if you will, for melanoma at this point. It's for lung cancer, other cancers out there. However, it is clear that if you have staining, the drug will work better. So you can do it. It may not help in terms of decision making, or it may. It's not been validated, and I talked about potentially either picking combination therapy versus monotherapy. That might be something to look at down the road. And I think also if you have a Bereft positive patient, maybe it might help, though we don't know. We don't know what the cutoff is. So long answer to a question, but it's a complicated field, and I think a lot of work remains to be done. I think the issue with an immunotherapy biomarker is more that it's not static, and it's variable whether you biopsy, which part of the tumor you biopsy and which metastatic lesion you biopsy could vary. Unlike the Bereft test, which is a static test, it's clear-cut, it's very reproducible from tumor to tumor in the same patient, and it doesn't change with time. And I think the days before we have, or the time before we have such a clear-cut marker with immunotherapy, I think it's going to be a while.
And the second question, what has been your experience with pseudoprogression when treating your patients with a checkpoint inhibitor? Do you observe more than less pseudoprogression when treating patients with a CTLA-4 inhibitor versus an anti-PD-1 inhibitor?
Excellent question. So the best way I can summarize this, that if you look at the data aggregate, I have a slide I didn't show, but there is the most pseudoprogression with CTLA-4 alone. There's less pseudoprogression with anti-PD-1 alone, and there's very little pseudoprogression when you put the combination. And I think that's logical, because when you put a more powerful agent, whether it's a PD-1 alone or a combination therapy, your responses are quicker and more deeper, and therefore that pseudoprogression is less of a concern. Now, I do want to mention that even with ipilimumab, pseudoprogression is not as frequent as some of us think. It's about 10, 15, 20% tops. With PD-1, it's 5, 10% or so, so it does occur with both. And I think the take-home point is that you need to be patient with your immunotherapy, but not too patient, of course, And if someone has really clinically significant progression, that's not pseudoprogression. And in fact, I don't like even the word pseudoprogression, because every progression is real progression. You only know it's pseudoprogression if it progresses later on, which, of course, doesn't always happen. I think the point really is with immunotherapy, you got to be a little bit more practical in your decision making, that okay, you got a new lesion, patient's doing well, I don't have any other options, let's keep going, maybe it'll stabilize, maybe it'll turn around. And also, I do want to mention, and I think people know this, but you don't need a CR with immunotherapy with these new checkpoint inhibitors to have a success. You can have a decent PR or even stable disease. Many of my long-term patients that are out many years from their initial immunotherapy have stable disease. And we never saw this before, but these are patients that you can get a scan on them every 3 months like I do, or 3 or 4 months now, sometimes 6 months apart, getting more adventurous, and this disease is still there. It just hasn't changed.
And then our final question, how do you decide which anti-PD-1 inhibitor to use when treating patients with metastatic melanoma? In other words, are there any factors that you think differentiate pemzolizumab or nivolumab when deciding to use one or the other for treating patients with metastatic melanoma?
Right, a very practical question. So let me start by saying that the clinical data with both these agents is virtually identical. Equal efficacy, toxicity is about the same. Of course, they have not been compared head-to-head. They're very similar molecules. One is fully human, one is humanized. The only difference, the clinical difference between these two agents is their schedule. So nivolumab is given once every 2 weeks. Pembrolizumab is given once every 3 weeks. Most of my patients prefer to come and see me less often, so they would choose, if they had a choice, they would choose the once every 3 week option. However, there are some patients that might want to come more frequently to the clinic and be monitored more closely, and they want to choose the Q2 week schedule. So it's a practical choice, I think, from the standpoint of picking between the two right now. There is no clinical data that will help you say one is better than the other. They're both very, very similar drugs.
Thank you, Dr. Agarwala, for the engaging presentation again, and thank you, audience, for participating. The webinar and slides will be available on our website, accc.iclio.org, shortly, and all the registrants will receive an email with the link. Please also register for the next 2 webinar installments on February 24th, where Dr. Agarwala will present Part 2 on adjuvant therapy for melanoma and practical considerations for immunotherapy. And March 15th, where Marianne Davis will present management of immune-related adverse events in patients with non-small cell lung cancer. Thank you and enjoy the rest of your week.